older age. So it is the patient have some kind of behavioral problems. What is the behavioral problems that he have here? Maybe he is euphoric. Sorry. So this is, oops. So this is the first case. Maybe the patient is euphoria. Maybe the patient using dirty language. So he has a problem when he's talking. And he's really in disinhibitions. That means he's kind of compulsive behavioral he is, I don't know, has a problem with eating, so you can say peculiar eating. So in this case, you know what I'm talking about, guys. The diagnosis will be right away. Maybe language also. Yeah, we talked about language. So the diagnosis will be right away. What is that? Quickly. Now, frontotemporal, right, frontotemporal dementia. Do you think there is family history here? In frontotemporal dementia, yes. So family history is positive in frontotemporal dementia. Diagnosis, what is the diagnosis here, which is also not so hard, is MRI. And the MRI, what you will see in the MRI, this is the brain. You will see really big ventricles around the frontal area, but the ventricles here down is normal. Why? Because from the name frontotemporal, that's mean the atrophy is here. That's why this is the problem. So frontotemporal atrophy. So the problem is just behavioral. And remember, the second thing about the behavioral is what? Family history report. Any visual problem? No. We talked about visual. There is no visual problems in Pick's disease or frontotemporal dementia. The second one, patient now is alert. This is interesting. He's alert and he's fine, but after a few days, the alertness is decreased. So alert, you can say positive, negative, or alternation. So alternate in alertness. He's not always alert. This is first. He's slow, as we talked about. He has a visual problem, and this is the only dementia that he has visual hallucinations. Visual hallucinations. Now the second question will be, what is this kind of dementia? And I think you know. What is that, quickly?
Lewy.
Now this is easy, which is Lewy body dementia. So you get the diagnosis at least of Lewy body dementia, which is shuffling gait, memory problems. So you're fine with that. Now, what you will find in Lewy body dementia, what is the organs that affected? Because here we talked about frontotemporal. Give me the organs in Lewy body dementia. That's just no. Lewy body means a kind of Parkinson. So you get a problem with substantia nigra. This is first. Locus coeruleus, which is this nucleus in midbrain. Right. What's the problem in these cells? It's degeneration. So basically degeneration pathology. So you will get here degeneration. And what you will see in histology, you will see this cytoplasmic inclusion body is called like this, called alpha synuclein. Synuclein. So you'll see this, this is the Lewy body in general. So this basically it's intracytoplasmic inclusion called alpha synuclein. I hope I write it right. Alpha synuclein protein, where either substantia nigra or locus coeruleus. So you get substantia, you get locus coeruleus in Lewy body dementia, while you get frontotemporal problems in Pick's disease. So you have to know, guys, the location, because he usually do that. I don't know really, but he usually does that. He will not give you the diagnosis. He will give you a substantia nigra region or temporal lesion. So you will know from the location that what he's talking about, which is usually the same case in step 1. So he's, I don't know, Fatima, I think she's struggling with internet. So you find now Lewy body. Now there is a trick here. How you treat it. This is important because there is a trick in the treatment. How you treat this Lewy body dementia. What is the drug that you don't need to give it to those patients? What is the drug that contraindication in those patients? Okay, 2 modalities of the treatment. Yes, guys, two modalities of treatment. The first one, don't give no to which drugs? No neuroleptic drugs. So neuroleptic drugs, neuroleptic, neuroleptic well? Neuroleptic, those drugs that antipsychotic. Hey, are you fine? Please, the one that he just joined or something, yeah, make it mute. So guys, neuroleptic drug, just basically these are antipsychotic medications, and these are anti-dopaminergic medications. Alright. So these drugs you'll give, he's already a kind of substantia nigra degeneration and leukocytosis. So basically we are talking about Parkinson. And then, so in Parkinson you don't have dopamine. And then you will give him anti-dopaminergic drugs. So what do you think? What's gonna happen? Worsening. Right, this is very important trick. This is the only dementia that worsening by neuroleptic drugs like halidol. And these drugs usually, guys, are common in dementia. Why? Because sometimes those dementia have agitation, delirium. That's why they give them antipsychotic medications. Most of them. At some point, maybe it's not daily, but at some point they give them halidol or even a typical antipsychotic. There is no rule for a typical antipsychotic in Parkinson or Lewy body dementia except to treat hallucinations. So you can, I couldn't hear you, Seima. Seima, you.
I think Ellen was trying to call you.
Oh, okay. Hey, I think he's here.
He said he doesn't have the phone.
How do you know? All right. I don't know he will be here. That's why I was not prepared. Okay, you got it. Cool. So guys, neuroleptic drugs, don't use neuroleptic drugs for Lewy body dementia because it makes sense. In Parkinson, in Parkinson you don't have dopamine. This is the problem with Parkinson. So if you use it, you will make it worse. But there is only one indication to use neuroleptic drugs to treat visual hallucinations. So you can say here, indicated to treat visual hallucination. Clear, guys? Is it easy? I mean, these tricks are really important, which is basically the test. Now, the treatment. What you will give to this patient. Remember, he's Parkinson's disease, and in Parkinson you have low dopamine, and maybe. So how you treat it, by the way? Which is, there is a rule for, because it's Parkinson, so maybe there is a rule for, wait a minute, let me remember. Because there is here, how come? Yeah, sorry, I don't think this treatment, so I don't want to talk about that because I'm not sure how I'm right, how far I'm right. So, yeah, I don't know.
Well, yeah, this second situation that changed it a lot. It's like delirium.
Yeah, but delirium, you are right, but delirium usually acute and just a few days will gone and usually secondary causes and big time agitation here in delirium. Patient really agitated. So, and usually we talk about delirium, I mean, we refer to delirium to any acute confusional state. But here I'm talking about years, right? Which is usually the definition of dementia, usually chronic years, and the one that is rapid also months, which is which is basically the Creutzfeldt-Jakob. So you are right, but this is alertness and alternate. This is, I mean, not daily basis, but it's a chronic. Let's say today and tomorrow, and then the rest of the week he's okay, and then another week, and also 2 or 3 days. So and another. So it's, you are running with months. So this is not definition of delirium. All right. So you got one, you got two guys, three. There are a lot, but you know I don't know how to make it. I always we will go again to this slide. Remember, we'll go again to this crazy slide and we will add stuff. But now let's go to just clinical scenario, which is the third clinical scenario, patient old age. So let's say the patient is all of them old age. So I will not mention the age, as we said. Hypertension and carotid bruit, which are very easy, right? Hypertension and carotid bruit. So the diagnosis will be just multi-infarct dementia. So this is not difficult. So I don't think you have problem to diagnose multi-infarct dementia. So that's it. Now this is behavioral, and this is a kind of behavioral. Another behavioral, maybe I can put it here, personality problem, plus wide gait, right? And he's psychotic, confused. So basically the fourth one, which is neurocephalus, right? So this is also easy. So I will move faster. Now there is interesting questions about dementia plus urinary. You remember, plus gait, and you made it, which is MPH. Now how you treat it? Just take the fluid out, which is basically CSF, right? Repeated spinal tap. So you'll do spinal tap first. You did a spinal tap for the patient, and the patient still have the problem. He's fine, but after 3 months, he came with the same problem. So you will repeat spinal tap. So after 3 months, still symptomatic. So you repeat. If you repeated spinal taps several times per year, I'm not sure how many numbers. So what next? Right. Right. So now no, not cortisone. Now there is indication for shunt. Shunt, which is basically ventriculoperitoneal shunt. I don't think the location is important, ventriculoperitoneal, but ventriculoperitoneal is the most common. So MPH treatment is the following. You will go spinal tap, do it. And then maybe you'll do it multiple, but then if you exceed certain limit of numbers, that's it. I mean, there is no way to do spinal tap every week. So the next treatment will be shunt. So this is the issues with MPH. Now another things with MPH, there is two pathology. Either decrease in CSF absorption, right? In arachnoid villi, we don't know why. Or obstructive hydrocephalus. Right, guys? This is also important. Because I told you he will not mention NPH for you. He will mention it's decreased CSF absorption. That means he is referring to NPH. The same thing, substantia nigra problem, which is basically Lewy body dementia, right? Or frontal problem, which is frontotemporal or Pick's disease. Okay, this is and you know, it's what you will see always as a kind of investigations, CT and MRI. I think this is, I didn't mention, by the way, CT MRI here because I think it just makes sense. All of them have CT MRI diagnosing, and you will see the whole ventricles just dilated, all over the ventricles just dilated. Any question before I will go further? No questions? Are you fine? Now hey, the background noise, please. Yeah. Now the prototypical example, which is the chronic one, right? Chronic one, and personality, functional, occupational. There are criteria. Basically, let's see if I have it. I don't think so. There is really the SMI criteria. I mean, you have to have it in order to say this is. Yeah, I don't think I have it. Sorry. In order to say this is Alzheimer's disease. Oops. I think that's also important, but I don't know. It's not here. Yeah, guys, in order to say this is Alzheimer's, it has to be chronic. It has to be now defect in functional, occupational, and social. So occupational. I'm gonna try to remember some occupational, gone, social interaction, gone. What else? Usually no psychiatric symptoms in the beginning. So you have to make sure there is no psychiatric illness, at least in the beginning. No psychiatric illness. And there is another too, by the way. This is DSM-I criteria to diagnose Alzheimer's disease. So you get Alzheimer, just MRI, you will see in the MRI, what you will see in the MRI? Diffuse atrophy, all the brain atrophied. That's why look at the ventricles be so big, because all the brain atrophied. So brain atrophy. Now you know these histology, which in histological terms, you don't need to know exactly what are these in step 2, but you need to know there are histological terms here, which is basically, what are these? Anyone remember? Neurofibrillary tangles. What else? It's amyloid problem, right? So it's amyloid deposition, neurofibrillary tangles. What else? Maybe tau protein problem. All of these guys, it's interesting because maybe he will give you these. So neurofibrillary tangles, I remember, amyloid, tau, all of that represent Alzheimer's. Now that's it to start with, but maybe treatment option, because all the Alzheimer's patients, not all, most of them, what is the problem with Alzheimer's? Basically, the problem with Alzheimer's, one of the problem, there is a nucleus which is Meniere's nucleus. I think it's, I'm not sure about also the spelling. This Meniere's nucleus have decreased acetylcholine. This is the pathology. So how you would treat those patients? Just give them high acetylcholine. So the treatment will be what? Increase acetylcholine. So how you increase acetylcholine? Basically just by usually the drugs that acetylcholine esterase inhibitor. Because when you inhibit the acetylcholine esterase as an enzyme, which is basically the enzyme that degrades acetylcholine, so your acetylcholine will be high, so the drug will be, well, there are two drugs. The first one, right, donepezil. The second one, tacrine. Alright, so you have two drugs so far, donepezil and tacrine, just, for acetylcholine stuff. There is another drug, but it's not usually with acetylcholine, usually inhibit glutamate. So it's usually inhibit NMDA receptor. So the drug, okay, we got these two. Sorry? Memantine, right. So memantine, you can put memantine. I don't know how to put it here, maybe. Memantine here. And memantine basically will inhibit NMDA and basically will inhibit glutamate. Because NMDA receptor is a kind of, it's a, NMDA receptor, it's interesting because it's ligand gate receptor, ligand with the glutamate and these stuff. So you will inhibit NMDA, and that's mean inhibit dopamine. Inhibit glutamine. Alright? So, these are important things about Alzheimer's. There is one trick, which is, I didn't mention it in my big diagrams. Alzheimer's plus, look at this scenario. She's 78. Sometimes she forgets, sometimes she finds. So she has forgetfulness. But what is this forgetfulness level? I mean, to what degree? Maybe she forget where she put the keys of the cars. Maybe she forget the name of someone. Right, so this is not big deal, forgetfulness. Okay, where is my pen? Mine is not writing. Wait a second. Hello. Alright, so that's the problem. Sorry guys, it's my issue here. Oops, I did. Alright, hopefully I didn't lose it. Give me 1 second guys, or a few seconds. You can take a break, I don't know what's the problem. But I know it's my side. Alright, that's good. Alright guys, so maybe it's forget, but usually it's mild, so it's not so severe forgetfulness. So usually forget maybe the name of someone, so you can say it's mild. Maybe forget the keys, where she put it, so it's mild. So she's still driving okay, social okay, and yeah, it's really mild things. No social, no psychological, no driving is fine. This is usually aging process. And there are also criteria for aging, maybe 5. It's really crazy, too much things. I think also a new word mentioned it. You just go, you need to just go through it, but I don't think you need to memorize it because it will be very easy. So this is how we'll differentiate Alzheimer's from aging. Aging, there is forgetfulness, but usually mild, just to one thing or two things, not daily basis, even at daily basis, but it will be so mild. All right. Any question, guys, so far? Now, what else? Yeah, I told you, it's just a lot. 60-year, let's say woman, homeless. You find her with, she's just talking haphazardly, so just mumbles. Maybe she has problem in the gait. You examine heart rate okay, blood pressure okay, deep tendon reflexes are fine. Your neck differential will be what? Homeless people always. What is the differential? The first, yeah, alcohol. Now the next question will be: give me the organ of alcoholic problems. What is the most common organ that affected in alcohol and the patient presented with dementia-like picture?
Mammary bodies.
Yeah, mammillary bodies, which is interesting. Although it's a kind of chronic, but so you are talking about mammillary or hippocampus. So mammillary bodies, maybe you can put it here. And cerebellum, basically, it's also important. Cerebellum and mammillary bodies. That's why those patients presented with these gaits. What is this mumbles means? Means confabulation, right? And this is the case, which is ataxia. And this is the memory problem. So that's it. This is alcohol. Right, so it's alcohol. So I don't think alcohol is big time. It's a big deal. It's you'll easy make it. What else? 60?
Doesn't confabulation mean the patient is making up a story?
Yeah, which is mumbles, just talking, whatever, talking something. Yeah, which story? But this story will be unrelated event, unrelated places, haphazard. It will not be really a typical story. It will just, he'll put something from there, something from there. This. Now, rapidly progression plus behavioral And here there is an interesting point. This is the only time I think you need to know the EEG finding, guys. The wave is really sharp and it's trivasic, so they call it sharp trivasic wave. Synchronous discharge. On your diagnosis will be, don't forget it's myoclonus here, so diagnosis will be Creutzfeldt-Jakob disease. And there is histology point also here important, spongiform. Alright.
And prion.
Right, which is prion, which is Creutzfeldt-Jakob disease. It's prion, right? So spongiform, yeah, it looks like sponge. I mean, I don't know why it's spongiform. The brain lesions, sharp triphasic synchronous EEG findings, behavioral myoclonus. I think the trick just rapidly progression. So you will see these within deteriorations in memory within 4 or 6 months. This is rapid, guys, because usually deterioration in memory needs years. Right, usually needs years, but this is right, kind of rapid. What else? This is, you get alcohol, you get these. What else? Also clinical scenario. Maybe a patient have depression. Okay, we'll make it here too. Mood, right, plus movement, which is choreoform. And you have to know choreoform movement does not mean always the dancing movement of choreoform. No, there are a lot of choreoform movement, like facial crimes, whatever, I don't know how to pronounce this, crimes or something. Like tongue protruding is also choreoform movement. So tongue protruding is also choreoform movement. Ataxia you can consider in the choreoform movement. Writing movement or dysarthria. So all of these guys choreoform movement. Now mood problem here. What is the mood problem in this Huntington disease? You remember I talked about depression, which is big time, but also sure there is dementia. Or maybe the patient just apathy. It's also mood disorders, just apathy. Now, 2 questions. Usually, this is the only dementia that you need to know it's really early presentation. Usually at the age of 40, family history positive, and autosomal dominant disease chromosome 4. Right? Family history positive, ataxia. Now, what is the organ? Because here also important, we are talking about Huntington disease. What is the organ, guys? Which is basal ganglia, right? Yeah, he said caudate because caudate is the most common. So basal ganglia or caudate. So again, organs are important here. Although you think this is step 1, but I don't know why they like it in dementia. So what we get alcohol, usually this cerebellum or mammillary bodies, which is organ-wise. We get basal ganglia and caudate in Huntington's disease. Creutzfeldt-Jakob, I think just the cerebral cortex, but you get some histology features, which is spongiform, is a kind of interesting here. Alright, so you get these 3 in this slide. Oh yeah, now I found the, sorry, because now I found it. Because I found it, so I need to go to make this slide more neat. You remember when I talked about Alzheimer's? So chronic means this is the first feature, which is chronic. The problem where in chronic impaired in cognition or cognitive behavior, and chronic impaired in occupation and social. So they put all of these together. Plus absence of psychiatric. So this is the second criteria. So we did 2. So the third part, they said no delirium. So make sure there is no acute presentation. Yeah, I think that's it. This is what I missed. Just what no delirium. Now, when I will go, or when you go back, guys, to this big slide, because this is the most important slide, I think, the first one. You will add some tricks right, to make it maybe, I don't know if we'd like to add some tricks to make it more complicated, but let's say I will just ask you. I will not add. Sorry, give me 1 second. All right, guys. So this is temporal. So remember frontotemporal, temporal. What is the thing that interesting here? Anything that was interesting when you talked about frontotemporal? I don't think so. Anything interesting, Critchfield Jacob? Yeah, it was rapidly and spongiform. So remember spongiform here was a kind of interesting. Huntington, remember these Huntington's family history and early. So you can say maybe early here, it's a kind of interesting. Sure, family history, positive. Lewy body, don't forget the rule of neuroleptic drugs. So I will say neuroleptic rules usually make the things worsening, or so you can say make things worsening. And the only indication to use neuroleptic drugs if the patient have visual hallucinations. That's why I put it here. NPH also there is something interesting because it's a treatment here interesting. We went with the spinal tap first, and then we went to shunt second. Neurosyphilis, I just mentioned personality problems, so nothing interesting. Oh, I think neurosyphilis also interesting because you are dealing with dorsal colon, so there is location here. Alcohol is important because you are dealing also with location, so either mammillary, right, and cerebellum is affected. There is cerebellum intoxication, by the way, due to cerebellar damage due to alcohol intoxication. This is very high. Now, vitamin B12, I didn't talk about, but dorsal colon affected. Plus, don't forget, we are talking about dementia, so cerebral cortex also affected. There is interesting point about vitamin B12 here. What else? And I think that's it. Subdural, I don't know how they make the question, but yeah, but it's very easy. I don't think it's hard. Yeah, I think I have to go through the subdural because there is a trick with this pathology wise, bridging the veins, evacuation indication, make sure the patient not on anticoagulation. There is some tricks, but I think I need to prepare it because now I forget them. And then HIV dementia, guys, by the way, those HIV dementia sometimes have depression, so that's why I made it here. So there's also another trick. So that's it, guys. I think that's the dementia approach. All right.